Hello, everyone. So, this is the third episode on the CCS sample practice questions that are in usmle.org. So, I have been recording my first CCS case, which is all of these cases we have for free right here. So, first of all, let's remind ourselves how to get here. First of all, go into usmle.org. After that, choose the step 3 sample test questions and scroll down, go into step 3 interactive testing experience, and right there you'll see the different options. So I already recorded myself doing my first CCS case, which was this one right here. Second CCS case was this one I recorded yesterday, and I already added some things to this game because it's actually, you have to understand the game and how the software works. So we'll try using this for the third case, which will be the one I will be doing right now. I have no idea what I will encounter, so I'm just going to walk you through whatever I do, good, bad, and you're free to comment in the comment section below if you liked it or have feedback for me. Remember, we're in constant learning and growth. So let's go for it. Right here we have inspirational music. So yeah, and let's see, start case. Let's go. I'll walk you through it, but some of the basics, maybe I'll go a little faster than previous cases, so be sure to see the previous videos as well. A 65-year-old woman comes to the emergency department because of severe left-sided chest pain. She appears anxious and diaphoretic. So first of all, she's not a 21-year-old, she's 65. She's already in an age range that we have to take into account for coronary artery disease, severe left-sided chest pain. Right here, that's important. Even if it's right-sided, it might still be coronary artery disease, but yeah, it's left. It's a little more suggestive. We'll see what else. She's anxious and diaphoretic. So this could be, this diaphoresis could be a coronary equivalent, or it could actually be an anxiety attack. We'll see what will happen next. Actually, I don't know if, for example, right now my time is running right here, but let's go on to the next section. So this is the first pop-up window you'll see, which is just like the chief complaint. Now we'll move on to the vital signs. So here we have that she is a febrile, she is tachycardic, bounding pulse, not only tachycardic, but it's also bounding, tachypneic, hypertensive, pretty hypertensive. This usually isn't solely due to an anxiety attack. These are very elevated blood pressures. We have to see what else we have. And body mass index is normal. So she is, we could say she's unstable because remember, Conrad Fisher's mnemonic: chest pain, shortness of breath, hypotension, confusion, and those all talk to us about perfusion. Okay. Let's see the history of present illness. We have to see all this before we choose to do anything. 65-year-old to the ED because of abrupt onset of sharp left-sided chest pain 45 minutes ago. She rates the pain as an 8 out of 10, severe. Let's see if we can underline. No, we can't. The pain radiates to her left jaw and to her back. This seems coronary a little. She is mildly short of breath, but the pain is not made worse by breathing or by a change in body position. So it's not it's not pleuritic, and it's not osteomuscular. She feels mildly nauseated but has no palpitations or lightheadedness. She has had no fever, chills, cough, or hemoptysis. Okay, the patient was diagnosed with hypertension 5 years ago and has since been treated with lisinopril and hydrochlorothiazide. She has been adherent to her medication and has not had any previous episodes of chest pain, either at rest or on exertion. Okay, this is very important because she hasn't had any pain, but suddenly she starts with pain. This doesn't seem as it isn't stable angina. This is unstable, or this is a STEMI or NSTEMI if we are going down the path of the heart. We'll see what else happens, which this is the most important thing we have to exclude. Past medical history, cesarean deliveries, the treatment, vaccinations up to date, family history, father died at 70, mother died of natural causes at 92, brother age 72 has hypertension, sisters healthy. Social history, widowed 7 years ago. Okay, so enough time has passed for grief and everything to have settled. Not active since spouse's death. Talking about sexual history, she identifies as white, doesn't smoke and drinks nothing special, uses no other medications. She's retired, educated, tournament bridge player. Okay, she walks daily. Strange. I didn't ask for any break. Review of symptoms. This is something important regarding my last case. In my last case, I took this as if they were already giving me the physical exam. This isn't the physical exam, this is review of symptoms. When you're asking the patient, you then have to go ask and go order the physical exam. Okay, so negative, 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 CHPI, you already read all this, negative. Okay, so now is the time we have the option of doing something. So in summary, first of all, we have to summarize the case. We have a 65-year-old woman, which has hypertension and has new onset severe chest pain that, let's see, and has not had any, that seems to be, yeah, it has typical characteristics, but we aren't knowing, it hasn't said anything about what happens when she exerts herself or nothing about nitroglycerin. So we can't define this yet as cardiogenic, typical, or the atypical, which would be 2 out of the 3 angina criteria. So that's what we'll check out. But this is very suggestive of coronary artery disease. So first off, what we're going to do is, before a physical exam, I would like an EKG. So I'm gonna ask for the EKG. Yeah, an EKG. I want her monitored, telemetry. I would also like a chest x-ray, not yet. I would like blood work taken, so CBC, basic metabolic panel, troponin. Yeah, we already have the rest right there. What else could I add right here? Chest x-ray isn't the choice right now. What is her saturation? Don't remember it, so let's check her vital signs. Let's confirm these orders. 12 lead, confirm order, and I also want an EKG, confirm order. Yeah, CBC with differential. Yeah, BMP right now, troponin. Okay, and we have that. I want to see her general appearance, skin, if it's cold or clammy, and all this. I want to see how her chest and lungs are, heart and cardiovascular. This won't change much. No. If you have cookies disabled in your browser, in private mode, please adjust. What? Okay, warning, an error occurred. Okay, what can I do next? So I'm gonna open this in another page. Just stick with me. We'll continue in in a different browser. We already have seen the most important part here is, yeah, that we are understanding where the case wants to take us, usmle.org. Let's see if I can get there. Accept the cookies, step 3 materials, sample test questions, go down to interactive testing experience. Very well. Case number 8, which is actually case number 3 of the CCS cases. Let's go. Start case. So yeah, in the actual exam, you don't have to choose your browser and all that. It will just happen. So we already read this. Okay. In our next video, we'll probably try to deal with the time better. We'll pay attention to the time. This one isn't exactly for the time. So first off, what we wanted in this patient is we want her monitored. So she's in the emergency department. That's the place I want her right now. She needs initial stabilization. Can't send her to ICU yet, although she'll probably end up in the ICU. Telemetry. Actually, if you write 3 letters, I think it might recognize it. Oxygen, I don't remember her oxygen saturation, but let's write this down. CBC, basic metabolic panel, and could ask for a chest x-ray. Let's see what happens if we ask for a portable chest x-ray. And well, if there's a STEMI, we shouldn't waste our time. And troponin, and what else? Telemetry, confirm orders. 12 lead. Yeah. Telemetry. Okay. CBC with differential. BMP. Troponin. That's a good place to start. And we want the physical, so we want general appearance, skin, chest and lungs, heart, cardiovascular. This won't change much, so I don't need it. And what's this? Not sure if yeah, we want follow-up, but I'm not sure if it's what will happen if I write that down. Interval follow-up, 2 minutes. General appearance, all this takes that time. What happens if we don't mark the interval? Let's see, general, skin, chest, heart, and we want her, how is her consciousness okay or not? Because these patients might, yeah, have problems very quickly. So the hypotensive, their Glasgow scale might go down, so you want to know how they are doing. Extremities, yeah, we also want extremities. We want to see how's the temperature of those extremities and the pulses. Okay, so mark okay. I already asked for those 2 things. Haven't checked the labs and haven't checked the physical. Let's see what happens with this. Okay, sinus tachycardia, check output of cardiac monitor by ordering check cardiac monitor. So let's do that. Check cardiac monitor. Current time is stopping will cancel. I already asked for several things, so let's go and see how they are. The entered time is equal to the current time. Okay. Well developed, well nourished, appear anxious and diaphoretic, severe distress from chest pain, diaphoretic, chest wall normal, diaphragm symmetric, tachycardia prominent and sustained apical impulse, S1 normal, S2 indistinct, S4 audible at apex. This is pathologic in S4 in general. If you can hear it at the apex, we will see what's happening there. Grade 2 to 6 diastolic, Decrescendo murmur, her best at the right sternal border. No rub, central and bilateral peripheral pulses bounding. No jugular venous distension, blood pressure equal in both arms. Diastolic decrescendo at the right sternal border. So this is right sternal border, but there is no jugular venous distension, so this could be decrescendo. Okay, so it's diastolic decrescendo. We're talking about maybe mitral stenosis. It's a possibility, but doesn't seem likely here. And the where we're finding this doesn't seem so as well. This could also be, don't think it's tricuspid stenosis, for sure isn't. Could it be aortic insufficiency? It could be aortic regurgitation, and this could go more with her pain. Extremity symmetric without no cyanosis or clubbing. Bilateral peripheral pulses bounding. So she's very hypertensive, and also I think she had a very high pulse pressure, meaning systolic minus diastolic is very high. So she could also have an aortic dissection. Okay, and the pain also went to her back. So, okay, we already have all that. Interval follow-up, I'm gonna mark okay. Total minutes, this will advance, but I don't want it right now because we just saw it. Now we want the results of what we asked for, and since we are suspecting a aortic dissection in the context of a patient that is unstable, we have to check something else. But first we have to remember they told us check cardiac monitor, and also I would like a echo, transthoracic echocardiogram. Let's see what happens. Check cardiac monitor, and I want no. Could first start off with an echocardiography. This is the best one to see whatever we have right here, but we first should see it's going to the back and all. I would like to see the EKG first, so let's see what happens with how the EKG is. So with next available result. Sinus tachy, we already know that. What else? Advance, okay, in 30 minutes. No, I want it fast. No, with next available result. I want to see that EKG. Sinus tachy, minus 10 degrees could be normal. P is normal. Increased voltage across precordium, okay. ST waves, non-specific ST segment and T wave abnormality. None. Sinus tachy, left ventricular hypertrophy. Left ventricular hypertrophy. Okay. Let's see. I'm still suspecting a chest x-ray. Yeah, let's ask for a portable chest x-ray. But she has severe pain. An echo. Let's go for that echo. No. But bedside. I want a bedside echo. Cardiac. Yeah, of course. Transthoracic, where is it? Let's see what happens. And let's see next. And let's see in with next available result. 12,400, a little leukocytosis, no anemia, platelets fine, differential, nothing special. Normochromic, normocytic, leukocytes, yeah, leukocytosis, okay. Sodium, okay, all of these seem okay. Creatinine is in the limit, upper limit. Troponin I is normal. So this isn't a STEMI or an STEMI. It could still be aortic dissection. The pain started shortly. Let's see what else do we have. Let's go for an interval follow-up and see how she is. Interval follow-up, but I think I have to mark these. Maybe. Okay, that's history. And could I mark? I want this one. Heart and cardiovascular. General appearance and skin. Okay, so the patient continues to have subdermal chest pain that radiates to her jaw and back. She rates the pain as 8 out of 10. Well nourished, appears anxious and diaphoretic. In severe distress from chest pain, cardiac monitor leads in place, diaphoretic. Tachycardia. Prominent and sustained apical impulse, S1 normal, S2 indistinct. A2, P2, what about that? S4 audible at apex. Grade 2 to 6, diastolic decrescendo, murmur. No rub, central bilateral bounding. Blood pressure. Yeah, we need the echo. We need indirect findings for she's tachycardic. Could this be a thromboembolism? We need an x-ray. Let's get that portable x-ray. Here we have the echo. Let's ask for x-ray, and let's also ask for D-dimer. X-ray portable. Confirm, we want it now. D-dimer. Might be a false positive, but who cares? Okay, and we're still in the emergency department. That's where she should be, and I want to treat that pain. She isn't hypotensive. Or can I see whatever we have? I want to see the information we have for now. Review chart, maybe? Vital signs. Could this be a hypertensive emergency? I didn't see any liver function tests in there. Let's add them. Lab reports, we already have that. Yeah, no liver function test right here. We have to treat that. We have to know what it is first. Let's add the transaminase. Let's add transaminase protein. We need all the fundoscopy. And what else? Another EKG. Let's see what happens. Protein, serum protein. Yeah. Another won't do harm, but I want to see next available. There it is. With separate, there it is. It's an aortic dissection. Left ventricle concentrically thickened and mildly dilated. That's why aortic regurgitation. So we got the diagnosis, high ejection fraction, but don't be confused because this is initially increased due to the aortic regurgitation. Okay, ascending aortic dissection. So we want to treat this with beta blockers. She is tachycardic, so let's order beta blocker. Let's see what happens. Beta blocker. These type, okay. Which one do you want to give? Carvedilol. Dilol. But oral, continuous. And her pain. We want to give something for her pain, but we have to treat this right now. No, this isn't the best idea. Cancel, yeah. So let's send her to, we need a transesophageal echo. Or did we see the ascending aorta? She's stable, unstable. She's with pain, so imaging, echo. That's what we saw in the echo. So let's see a transesophageal echo. Cardiac consultation. What we need is, let's see, it's the ascending aorta. Consultation, cardiovascular consultation. Cardio, no, surgery. And we want to pass this patient off his home ICU. (37) pulse, 110 bounding, 22. We already know this. Let's see what else we got. So we have to control this patient's pressure. That's what we have to do right now. We have to stabilize the pressure. So let's write orders. Carvedilol. And she's using could we give her morphine or something for the pain? Not an NSAID, acetaminophen. She has a lot of pain. That's very severe. What else? That's it. Exit case because we can't do anything else. Okay. So, and block. Now let's see what else comes. The explanation. Right here, if you click on start next block, you'll see the feedback. Let's see how we did. That's the important part. A 65-year-old, yeah. So, sharp, left-sided chest pain radiates to her left jaw or back. Began abruptly 45 minutes before coming to the ED. Okay, she also has hypertension, no history of previous episodes. Physical exam shows the hypertension, tachycardia, anxious, diaphoretic, severe pain, the indistinct S2. So probably this is due to the aortic regurgitation because usually it is A2 and P2. But if there's aortic regurgitation, A2, the aortic component of the second heart sound will close after, meaning it probably closes at the same time as the pulmonary, so indistinct S2. With S4, and usually the S2 main sound originates from the aortic closure, so if it's not closed in very well, you'll probably won't hear it. Okay, oh, we didn't check this one. Neck examination, this was important, so we didn't get this information. Arteriovenous Nikken on fundoscopic examination. That's, remember I mentioned a fundoscopy? I thought that was included in the neuro exam that we did ask for, but no, it's hint. Hint what actually meant, let's see, it was all this upper otorhinolaryngology, and it was ear, nose, throat, and head. So that was what we had to ask for. The remainder is unremarkable. This would seem most consistent with coronary or aortic abnormality. Correct. Okay. In the widened pulse pressure we talked about, there it is. The computer-based case simulation contains thousands, yeah, that there's many options. The important thing is to include what's very important, which is efficient approach would include performing targeted physical examination. We did that. We did exactly this. We ordering a 12-lead EKG, did it. Portable X-ray, we did it, wasn't the first step, we did it like the second step because we wanted to be sure it wasn't a STEMI first. So we didn't waste time asking for the X-ray. Optimal medical therapy would include stabilizing with IV medications. Basically, we didn't do that. We gave perorally carvedilol, very bad treatment. Suboptimal treatment would include other antihypertensive agents. So we did it, not that bad, but suboptimal. Lastly, IV narcotic administration. Yeah, we did that. We gave morphine. But it took us some time, right? But I'm not sure. I wouldn't have given morphine before ruling out right STEMI, because that could have, if it was a right STEMI, we could have done more harm. Okay, but we could have acted a little faster. Once stable, some form of chest imaging that would assess for an aortic dissection, CT of the chest, or transesophageal echo. So in general, when the patient is unstable, you go for transesophageal echo. If the patient is stable, you go for the CT. I didn't go for the CT because this patient is basically unstable. So instability isn't just cardiovascular collapse. Instability is also the mnemonic, chest pain, shortness of breath, hypotension, and confusion. So although the patient was hypertensive, the pain was severe, there was chest pain and all, we could make the case that the patient was unstable technically and go for the transesophageal echo. But well, both options were available for you. The diagnostic workup should include blood tests. We already checked the creatinine, which is the BMP. We also checked electrolytes. We checked the CBC. I didn't check creatine kinase because it's not that specific, so I went for troponin, but it's a good idea to check for creatine kinase because it might give us something, right? In general, we ask for it. Not necessarily go for myoglobin and all those outdated enzymes, but creatine kinase makes sense. Mainly the MB portion, which is more cardio selective. And a blood group and cross match. I was thinking about sending that, but I didn't send it because I just thought it wasn't necessary. But I guess that all patients that end up in surgery, remember blood group and cross match. So once the aortic dissection is discovered, the aortic root involvement confirmed, yeah, you have to go for heart surgery, endovascular, blah blah, TEVAR, endovascular aortic aneurysm repair, thoracotomy. Yeah, so that's what's decided by the cardiac surgeons. I'm not sure if we have to write this out in our orders or ask for the consult. Timing is critically important mainly in this case. So yeah, during the first 2 hours of simulated time, I actually don't remember. I'll go back to the video and see what I did in those first 2 hours of simulated time, because of course minutes have passed for us, but you have to pay attention to the minutes of this simulated time, because more than an hour without diagnosing this patient and treating isn't good. So for every minute a patient has aortic dissection, mortality increases a lot. So yeah, examples of additional and more in the type A dissection. Suboptimal management would include ordering additional physical examination components, okay? Administering an IV antihypertensive without a beta blocker. Yeah, first thing is beta blockers. That's the most important you have to give. It reduces the stretch on the aorta and the shear stress, so reduces the rate of expansion. It would be suboptimal to order anything unnecessary that would waste time, even if the test or procedure were not invasive or risky. Lung scan, no, crazy, for sure. I agree. Examples of poor management would include failure to order any physical examination. So this time I did order physical examination compared to my previous CCS case in the previous video, where I thought that the physical was where it said review of symptoms. No, sir. Review of symptoms is when you ask the patient, or maybe seeing. No, it's when you ask the patient, I believe. It's not you assessing the patient. It's not the physical exam. So you have to always ask for the physical exam in all your patients. Failure to administer an antihypertensive agent or failure to order surgical intervention. Yeah, I asked for surgical consultation. I'm not sure if I had to ask for surgical intervention or endovascular aortic repair. Not sure, but I believe surgical consult is important, or they are the ones that decide. They have to run fast. Examples of invasive and non-invasive actions that would subject the patient to unnecessary discomfort or risk. Okay, let's see if we order any of these. Chest tube, no. Changing the location to outpatient office or home, no. I changed the location to the ICU. Seems better. Exercise ECG, no. heparin, no. Laparotomy, no. Needle thoracostomy, no. Stress echo, no. Thrombolytics, no. Warfarin, no. Okay. And yeah, that's it. So see you in the next one, and we'll grow case by case. So hope you liked it. You can compare how we are progressing, seeing the previous videos. I would recommend you actually trying the case by yourself and then going back and see what I did, and yeah, the idea is we grow together.